I always want to say, I always want to share that I'm joining from a very hot place. That's why I take advantage of this. Sorry, Pallavi, over to you.
Good evening, everyone. So, today's topic will be pediatric pain assessment and the management of persistent chronic pain in pediatric patients. Myself, Dr. Pallavi. I'm DNB Palliative Medicine, currently working as a registrar in Baswatarakam Cancer Hospital in Hyderabad. So today we will have two lectures, one by Dr. Spandana Rayani ma'am and one from Dr. Kritika Rao ma'am, and two case presentation which will be done by Dr. Pallavi Singh ma'am and Dr. Sakshi. Uh, so first I'd like to introduce the faculty. So, Dr. Spandana Rayani ma'am is one of the core member of this program. She's MD Pediatrics and fellowship in pediatric palliative care. She's associate director in Sunflower Children's Network and Two World Cancer. Uh, uh, Second lecture will be by Dr. Kritika Rao ma'am. She is MD Palliative Medicine. She is working as assistant professor in the Department of Palliative and Supportive Care in KMC Manipal. Case presentation will be done by Dr. Pallavi Singh ma'am. She is MD Palliative Medicine and working as an assistant professor in Tata Memorial Cancer Center in Varanasi. Then last case presentation will be by Dr. Sakshi Bhatia. She is pursuing right now DNB palliative medicine second year in Mahavir Cancer Center, Jaipur. So uh, I will request Spandana ma'am to start the today's session.
Thank you, Pallavi. Uh, uh, I want to ask the other Pallavi if she wants
Yeah,
to
I'm
go first.
sharing, ma'am. I'm
Yeah,
sharing this.
thank you.
So, is my screen is visible to everyone?
Yeah,
Yes.
just need to make it slideshow mode.
Yes. So, as we all know the today topic, so there's just a quick question for everyone here in the room. There is a boy who is 13-year-old and he is a known case of B cell acute lymphoblastic leukemia. He has a history 4 months post allogenic BMT and present with very severe crampy abdominal pain with a history of bloody diarrhea presented in our pediatric palliative care OPD. So, what all what you think to start for this patient? Any NSAID or opioid infusion or oral medication in a child with having a severe pain and this degree of uh, gastrointestinal symptoms. So keep your question in your mind, and we will come on this later.
Thanks, Pallavi. Pallavi, just so that you know for the next time, we couldn't see it in slide mode
Okay.
and it didn't go into slide mode for some reason. And Pallavi, can you see mine in slide mode? Like, did it
No,
move?
yes, ma'am. Now it is in slide.
Yeah,
Yes,
thank
ma'am.
you.
Yes.
Before I move further, I just want to say thank you everyone for being here. And it's always a pleasure sharing this platform with such fantastic doctors such as Pallavi and Kritika. Very happy to be here. It's a very good question that Pallavi has asked us today. What medication would you start for this child? But before we go there, I think we are going to talk a lot more about what are the other things that are important to arrive at that diagnosis. And I think this is very important because a lot of the people at the end of the day think that, yeah, palliative care people will come and start morphine for the child. That's what they do. But that's not exactly what we do. There is a whole lot of thinking that goes behind, even when we start morphine for a lot of children. And I want to dissect some of them during the first half of the talk related to assessment of pain in children. Just thinking about this quote, I think as doctors, we think that we have to cure every time, but in reality, we are able to cure sometimes. We hope to relieve often, And I really, really wish that we are there to comfort the patients always. Again, the slide is to show you that a lot of the times, since many, many years, decades, in fact, we have accepted pain relief as a fundamental human right. Is it seen in clinical practice is something only you can answer, and I can answer within the context that I work in. But we have to remember that World Health Assembly has said that it is an ethical duty of healthcare professionals to alleviate pain and suffering, and this extends to children too. And then when you look at all the studies that have happened over the years, the one thing that we commonly see is that symptoms in pediatric palliative care, one of the most common symptoms that we see is pain. They say 62% in this particular study, but more and more studies coming out of low middle income countries, especially end of life in communities, show that 80 to 90% of the suffering is contributed by pain. And then when we think about pain, we did speak about it last week about the concept of total pain, about how assessment in palliative care is not just physical. Even though we are all physicians in this particular room, when we go to assess a child, we are thinking about the physical, psychological, social, and spiritual concepts when it comes to the pain part of it. And when it comes to the assessment part of it, we are thinking about assessing, implementing the plan we build, and then reassessing the child. So, assessment is quite important in the whole process of implementing a pain relief plan. And how do we assess pain? The pain assessment that we do should be appropriate, should be frequent enough, and it should be clearly documented. And as I talk about these concepts, I want you to think about in your current practice as an oncologist or a general pediatrician, or even as a palliative care physician, how many times are we writing about the pain in great detail? And then when we think about how are we going to assess these children in pain, always remember to combine the child and family history, assessments by the bedside nurse, because a lot of the times we do the rounds, we exit the ward. It's the bedside nurse or the ward nurse who is staying there listening to the screams of the child. So nurses are always better assessors of pain compared to physicians. Physiologic parameters. We will talk about the pitfalls of it, but they do have a certain role in assessing pain. And then thinking about what are the pain assessment tools in itself that we are going to use. So this is one tool to look at history. I'm going to show you 3 tools in the next few slides. Again, you can choose whichever one you want. I like Socrates because I think it's much more clear. And this is Socrates plus impact, right? So S is site, where is the pain? O is onset. When did the pain start? Is it sudden? Is it gradual? Character of the pain. How does the child themselves describe the pain? Radiation. Is it only in this place or does it go anywhere else? Associated symptoms. Is there constipation? Is there disturbed sleep? Timing of the pain. Is it more in the morning? Is it more in the evening? Did it start in a different way? Did it change over a period of time? Exacerbating and relieving factors. Thinking about severity of pain. And then how does this pain impact the child? And I want you to remember each and everything you see here, such as mood, sleep, play, feeding, mobility, and school attendance. How does it affect them? So all these things are very, very important when it comes to a child's life and the impact of a symptom on them, right? And if you think about it, you can use Socrates for any other symptoms that you might see in a child, like vomiting, breathlessness. You can substitute pain here into how they feel, when did it start, and all these things, and take a very good history. And then there is the OPQRST-UV that you might choose to use instead of Socrates. And then we also have Quest. So Jyoti has the slides and you will receive the slides. So we don't have to go through all these. The reason why I'm showing you this is you might be more comfortable with a particular type of tool, particular type of history taking, and you can use any of the three here to take a detailed history. And then to remember, there are two ways that we use pain assessment in emergency department setting, right? For example, a child comes with pain in the right iliac fossa, and we are all thinking about appendicitis, right? So it's a diagnostic indicator. But then, how many times do we use pain as a symptom that requires treatment? Even in fracture bone, at least when I was practicing as an intern in orthopedics department, pain relief was not the first thing that was in my mind. Oh, I should shift this child to the X-ray room. I should send this child to this particular referral. This would be my priority rather than relieving the pain of the child. And I think that is quite symptomatic of how we do not care about pain as symptom that needs treatment. Rather, we are looking at it as a diagnostic indicator. I think there should be a balance between these two and a good symptom management plan for these children. And this is a question for those of you listening in. How frequently do we assess pain? In the last 1 week, starting Monday to this Friday, how many of you have written about pain? How many of you have assessed pain? If you can type in the chat, Pallavi Ghosh will help us look at the chat and she will read out the chat messages. Pallavi, I see
Dr.
some. Yeah, go ahead,
Dr.
please.
Lavanya say once a day.
Okay,
So
that's good. Any other responses? How many children have you assessed pain for?
Dr. Aruna says once or two times a week.
Okay.
Dr.
Is
Prabha
it the,
twice.
hmm,
Dr. Aruna, once or twice a week, ma'am.
yeah.
Dr. Prabha twice. Nikhila, all the patients, Dr. Tasha daily, 8 hourly. So they do it in pediatric ICU. Then most of the people are saying once a day. F- yeah,
No, you are all much better than me because when
daily.
I was a resident, pediatric resident, I didn't do it often. Thanks, Pallavi. So, how frequently should we do? Ideally, if a child is at high risk of pain, like severe burns, fractures, or any pain conditions, cancer pain, severe pain, ideally we should look at pain every 2 to 4 hours. However, we know how difficult it is for the nurses to look at it. So, at least every shift, we need to get a pain assessment thing. So, when the shift changes, we need to ask them to note down the pain score. At least that way, we will get it done 3 times a day. And thank you. Some of you are already doing that. That's fantastic. So again, this is something else I'm asking you. Please put it in the chat as we go through them. The first case vignette is a 2-year-old child got diagnosed with Wilms tumor and is reporting pain. Remember, I'm not saying he's complaining of pain. Of course, this child is not complaining. They're reporting pain. They are saying they have pain. So, what scale or tool would you use to assess this pain for the severity of pain? A 2-year-old. I'm just going to give 10 seconds because I have 3 case vignettes. Pallavi, any answers
So,
coming in?
doctor, yeah, so flak is the most common answer, and few people have said flak R also. Face reading scale has been answered by Dr. Dexy. Yeah, but flak is the most common. Dr. Tasha has answered visual analog scale and plaque. Yes.
Fantastic. Let us talk about the second case vignette. A 5-year-old is on treatment for AML since 1 year and is reporting burning pain in the feet. For a 5-year-old who has been taking treatment for a year, which scale would you use?
Yeah, Dr. Juberia has answered VAS. Face, Von Becker has also been answered. Von Becker and face, NRS. Yeah, few people have answered NRS. faces. So majority of people are answering faces and VAS, visual
Fantastic.
analog scale. Yeah.
Thank you, Pallavi. And the last case vignette, this is a 12-year-old with osteosarcoma of left femur and is reporting pain. What scale would you use? Close to an
Yeah,
adolescent.
so NRS, most people are saying NRS. Dr. Sachin has said FLECR, but yeah, everybody is saying NRS.
Fantastic. Thank you so much for the responses. And this is great. I can see more chat messages coming in, but let's move on. So, going back to assessment of pain, what the tools that you have mentioned definitely have a role. But beyond anything, we have to remember that communication, that is self report and parental report, are the two most important things that we cannot discount when we are assessing pain. And then you have mentioned some observational measures such as behavioral scales. And then sometimes we might also use physiological changes to support our findings. So, going back to assessment of pain, always remember self report of pain is the gold standard. A child can tell you they are in pain, then they are in pain. So again, we have to remember a 2-year-old can report pain. And this is fantastic from you all because none of you said, no, 2-year-old cannot report pain. Any child, I think beyond 1.5 year, even 1 year, start saying different words. Like in Telugu speaking land, they say Abu, I. So they say that Abu Aindi, which means they got hurt. So they choose different words instead of pain itself to represent that, to report that they have pain. Again, here are some of the scales. Some of you have mentioned FLAC, some of you have mentioned face pain scale, Wong-Baker scale, visual analog scale. As you can see, all of them have a role. And you're right, face pain scale can be used in children more than 4 years. FLAC can be used in non-verbal children of any age. But there is role for cognitively impaired children, especially between 4 and 18 years. But I have used FLAC in much lesser age too. So I agree with you. Most of your answers are correct. So this is numeric rating scale. Usually children should be able to seriate, which is they should be able to say 2 is more than 1, 3 is more than 2. They should know that seriation. And that is why sometimes it is children 7, 8 years who can use numeric rating scale. And the way you ask them is 0 is no pain, 10 is the worst pain you can imagine, right? It's not worst possible pain, but instead in our local language, we will say 10 is the worst pain you can imagine. And based on that, they have to rate it, right? And some of the children, we use faces pain scale revised. And this is not matching the face with the face of the child. This is us showing this to the child and asking them, how much pain do you have? Not how are you feeling? Because sometimes we are not in pain, but we are still feeling like this, right? Like it's a bad day, I'm feeling like this. So it's not feelings, it's pain. And then Wong-Baker scale. I began using Wong-Baker scale when I started pediatric palliative care practice 10 years ago. But within a year or two, we have stopped using this because one, these faces are not something the children can relate to. These are cartoonish faces. As you can see, this one has tears and as they say, mard ko dard nahi hota. Lot of boys don't like picking a crying face because they are strong, and they also come in colors. And sometimes when they pick a particular face, I used to ask, "Is it? Why did you pick this?" And they're like, "My favorite color is blue. My favorite color is yellow." So, I mean, if this is the one you're using and it is working, that's okay. But I just want to share that these are the particular reasons why I stopped using this one and I use this one currently, faces pain scale. And the other one, sometimes children don't like telling you how much pain they are in. They don't like a number. And at that time, no matter how many times I have phrased it, they don't give me an answer. I usually say, is it this much? Is it this much? Or is it this much? So I use verbal cues along with some visual thumb, forefinger, or two hands to ask them how much pain they are in. And then we know this, especially I think closer to adolescent, if they don't like giving numbers, they might say things like how much pain they have, mild, moderate, severe. And then you people have also mentioned visual analog scale. This is a bit tricky. Some of you have used it for a 5-year-old. I'm not sure how effectively they're able to point out using a visual analog scale because I think some kids do struggle with that. So just be a little mindful of that. And a 5-year-old, I would say faces pain scale revised is a better one. So, do children always report pain? Do they under-report pain? Do they over-report pain? Any thoughts about that? I'll just give 10 seconds because I just want to be mindful of time too. Any thoughts about that? Under-reporting, over-reporting, or they appropriately report?
Under report, Dr. Lavanya and Dr. Sajita has replied, underreported. Few people have said overreported. Depends on the
Fantastic.
age, Dr. Aruna has told. Both can occur. It can be age related, dependent on child threshold.
Thank you, Pallavi. I
Overreported.
think Yeah, I think this is one thing I think we can take away from this. A lot of the times, pain is underreported, not overreported. And the good reasons are I don't want a needle. If I say yes, you will keep me in the hospital for longer. I am a good child. I don't complain. If I say I'm in pain, my mother starts crying. I hate hospital. I want to go home. These are the reasons why children usually don't report pain. And I think observation is one other thing that we have to remember. Again, I wanted to ask this question, but I will move on with that. I just want to say newborns feel more pain than you and me with the same insult because their excitatory pathways, which are the pain carrying pathways, are very well developed and their inhibitory pathways are not well developed. So, babies, those of you working in NICUs, they are feeling more pain. So, we need to control their procedural pain and also their natural pain that exists because of the disease. And then I always look at this and I think that how can I say this child is in pain? Because might need a diaper change, might be hungry, like there is no difference, right? So, yeah, this might be an indication for pain, but I prefer using NIPS, which is neonatal infant pain scale. And all the NICUs I work with, we do it at every shift change at least. And as you can see, based on how much, there are a total of, I think, 14 points. No, 9 points. And then based on this, if the child scores more than or equal to 4, then we consider them to be in pain. And then, as I said, pain activates sympathetic nervous system and there are physiological changes, but do not use physiological indicators to rule out pain. So once I had a child who was screaming in pain and his heart rate was 80, right? Or 90. And my nurses were like, no, 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 he's not in pain. Look at his heart rate. But my point was this child has been in pain for 6 months. He found us after 6 months. His body is not going to react as if he had a appendicitis or as if he had a fracture bone. His body adjusted to it. So physiological indicators are not for ruling out pain, rather ruling in pain, right? So just be mindful of that particular thing. And this is the FLACR scale. And if it is 3 or more, then you're a little more alert to making sure the child is more comfortable. And this is used for cognitively atypical children. And again, we say 4 to 18 years, and there is a very long scale which I couldn't fit on a slide, which is called non-communicating children's pain checklist. Especially if you're working in developmental clinics, this might be a better scale for you for children with autism and cerebral palsy. And just remembering, as I said, children who cannot see it cannot report pain well. Therefore, they don't give a good number. And for children, most of the times, yes, I have pain. No, I don't have pain. But there is no in between for them. So that might be more difficult with assessment of pain in children. The other thing to remember is the reason why I brought in that child, 5-year-old child, AML child for 1 year. A child who has been in pain before uh, is able to express pain better next time. But if the child came to the hospital for the first time in their life at 10 years, they might not have the same language as a child who is 5 years and taking treatment for 2 years. So I think that is the other thing we have to be very careful about when we meet this very mature 4-year-old, 5-year-old who has been in the hospital since the time of birth or later. So that is one thing to remember. And also where they are, whether they are separated from their parents or not, how do they cope? All these affect the assessment of the pain itself. This is a beautiful scale. It's called Individualized Numeric Rating Scale. Again, if you're working with neurometabolic conditions, genetic conditions, parents know their child much better than you or me because they are with them all the time. So the parent makes the scale themselves. But again, the parents need certain discussion to be able to arrive at this. As you can see, this particular child is talking, smiling, giggling here, is making wailing noises, moaning. Here, the child is crying and then screaming loudly. And then the thing I want to show this is to tell you that we as doctors can identify pain only when the pain is more severe. If the pain is moderate or mild, doctors are not very sensitive to it, is what this paper says. And then the other thing is, all of us, physicians, nurses, and parents, we all tend to underestimate a child's pain. Again, this is based on evidence. And as the pain intensity increases, even the difference between how much we are rating and how much the child is rating is also increasing. And then nurses are always focusing on how overtly distressed the child is. That is why when you write morphine PRN, we say PRN stands for patient receives nothing. No nurse gives PRN, at least in my practice. And again, of all the people assessing the child, parents seem to come the closer to what a child is feeling. And as I said before, a quiet and calm child who's telling you I'm in pain, don't mistake it for, oh, they're not experiencing any pain. So I'll stop over here and hand it over to Kritika.
Thank you, ma'am. Ma'am, there's one question, just if you can reply in one yes and no. So Dr. Lavanya asked, physiological indicators could work in acute pain, not in chronic. Uh, or should we take the question afterwards?
Sorry, I just realized I'm on mute. Let's take it afterwards.
Okay,
But
sure.
I'll reply on the chat in the meanwhile, Pallavi.
Sure. Yeah, thank you, ma'am, so much. It's always pleasure to listen to you. So next lecture will be for the principle of management of pediatric pain, which will be taken by Dr. Kritika, ma'am. Yeah.
Hi, good evening, everybody, and thanks, Pandana, for really covering up. It's a vast topic to talk about, and I know it's not never easy to even cover it within the 15 minutes that you try to manage to do this. The entire perspective that Dr. Spandana has given you is actually also forming a basis for me to talk about principles when you're very core principles. We're not going to learn management in this, but you're just going to be touching upon why it is important to manage pediatric pain and where does it really stem from. So when you look at it, uh, pediatric pain really matters to us because, as a lot of you highlighted, that it is common in your practice and you've been doing it as once in a day at least to assess it. But you also notice that a lot of children underreported. A lot of them don't tell you because, as Spandana has pointed out, bravery. They want to show a brave front in their favorite doctors, or they don't want to appear weak. And they've been told that if you're strong, you will be rewarded. So they look for that. And then, hence, a lot of times it is underreported and undertreated as well because we fail to recognize it as well. And this has a significant impact in overall their psychological well-being as well.
Because as these children who have repeated experiences in the hospital, coming with pain which is undertreated, not assessed correctly, probably due to that, or not having access to pain medications as well, can have a significant impact on their well-being in a way that, one, their sensitivity to pain is very, very low. They might be able to catastrophize it. They start getting anxious, they start feeling very, very anxious, or they have panic attacks when they come to hospitals. Even sitting outside the doctor's chamber sets them into a panic attack phase as well. And that can hamper the experience of the child while they're undergoing treatment. A lot of these kids with chronic illness will keep coming and again, maybe monthly, 6 monthly, yearly, or cancer patients will be there almost every other week. And that significantly impacts the lived experience of a child and the parent together, because this memory is going to be the core memory that they will retain. And thereby it also impacts their recovery from various things. If the pain is not controlled, they don't eat well, they don't sleep well, the parents are they're stressed, they are not able to recover from the whole hospitalization phase, they go back home, it's the same thing that continues. The family satisfaction also matters, because your entire purpose of being able to meet with this child and the family is be able to provide the good care. In the end, you also ensure that they want to feel satisfied with the comfort that you provided, the care and the treatment that you provided in the hospital and at home or on OP visits. So, which is why it's so important, and we are dealing with pain over three vast topics in this entire course structure. So, as I talked about, and Spandana just mentioned that we have discussed about why pain is total pain and it has a biopsychosocial model. There is a neurohumoral biochemical mechanism by how pain really evolves in. Because pain has a lot of emotional component to it, how we perceive it, how we have dealt with it, our cognitive and understanding of it, that influences along with the physical nociception process that occurs. And how pain is managed overall affects the well-being in a way that physical well-being, their ability to do things, being independent, their emotional well-being, is their mood better? Are they able to perform their daily activities? Are they able to interact with other members in the family? So all of this is important. One of the major issues that occurs about is we feel that children do not have spiritual distress. And that's one of the commonest thing that surfaces, like, palliative care physicians are used to assessing, but in general practice, it is, seldom looked at. Now, reason why being is that we always look at spirituality, someone that who has learned in his life or has life experiences, and they've gone and lived a good amount of years in the society for them to gain experience and then feel that, oh, I have a certain connection, I have a certain faith, and I have a certain belief system. But as simple as distress in child could be even just about why me. Simple. We had a child who had come to the OPD, and random conversation while we were doing a blood draw was that, why am I coming to the hospital every other day and getting all of this blood tests, and my friend is not there in the hospital? He is absolutely fine. This is a 5-year-old child who is aware that he has to come to the hospital because he's sick. He doesn't know yet what exactly is going on, but his parents have told that he's sick. And why am I supposed to get this prick every other day? Why can't my friend come along and give him as well? That simple thing of why me can also exist for a child. And if you are to sit down and probably understand that perspective, sometimes that distress itself will make them not turn up to the hospital, or they cry, they howl when they're entering. And the parents sometimes refuse to bring the child on that day when they're supposed to be appointed, because the child will start having those harrowing experiences in their mind the previous night itself. That tomorrow I'm supposed to go to the hospital, and they start hyperventilating, they'll start panicking, they don't sleep, they don't eat. So, such is the impact of an undertreated pain in our children and in the society overall. So, as we talked about that, over a period of time, due to the neurohumoral and biochemical mechanism, there's a significant stress which affects most organ function. A lot of inflammatory disorders start developing as they age, and things continue to be, the chronic pain is unrelieved, and there could be issues with that, and develop a significant fear of the hospital treatment, in adulthood, there has been reports that they refuse to come to further any care in the hospital. The entire environment disgusts them, and they prefer to be at home, not take treatment, even if it is a life-saving treatment, or even if they have to come in. For example, it can affect fear in a way that if their parents, they're known, somebody is in the hospital, but because of the whole harrowing experience they had in the hospital, they refuse to even turn up. They can't face that environment again, and that itself can trigger a lot of difficulties for the child in adulthood, later on in life, and for the rest of the family as well. So there are these myths, as Dr. Spandana just pointed out a little bit, highlights about what happens, about how do children feel pain or they do not. We've all understood that yes, even a neonate is able to feel pain. The way they express would be very different. It may not be like a child 5-year-old or a 7-year-old that they will be able to speak. They'll be only able to show you with certain behavioral changes. And it's important to also understand that we feel that children may not remember pain. Why will they? Because it's just a one-time incident, but they do know. Even they'll pick up your words, they'll cues of what you have spoken for when a procedure is being done. And oftentimes, sometimes when we are at the bedside for the child and we are talking, and they'll come up with these random questions about it, and they remember what you have told. Because the next time they'll ask you, this is what you had told me about my pain or my problems, and I am now again asking you back about it. We've highlighted and we've cleared that, yes, they're able to report pain, or we have various ways that we can use observational tools to assess for pain. Exaggeration of pain occurs, catastrophization occurs based on their past experience of it. Because previously their pain might have not been addressed. And now they're not able to know, how do I express it? What do I tell for? And the most common thing would come up is about opioids. Opioids use in general practice. There's so much of fear around it. And their thought is about children may not be able to tolerate opioids. We can't give so many drugs at home. It's very difficult to monitor a child with morphine. What if the child develops respiratory depression or addiction and things like that? For that, I'll give you one example that occurred with us. There was a child referred from NICU with osteogenesis imperfecta, and poor thing, baby had a fracture during birth. And as soon as after delivery, because of the prognosis of the child and things, we were called in, and along with discussing goals of care with the family, we were also helping in the NICU to handle pain. And we were requested that whether could we start morphine infusion while the child was in the NICU. We did that. They managed the child, comforted, addressed the fracture, plaster, everything was done. And then, because the goals are only comfort care, plan was made that the parents would like to take the baby home and manage with a local pediatrician in their hometown, which was some 200 kilometers away from where I practice right now. Simple thing that it was about, okay, we have to convert into oral morphine and continue this at home for the baby to be managed well. There was a significant anxiety amongst the neonatology team that how can we send the child home with morphine in hand, and what if they overdose and they give extra doses and they manage to do that. One simple thing that we realize is we forget that parents, especially the mother, she's in tune with the child. I'm sure that she's going to be very particular about the dosages. She'll monitor the child. If you explain to her what all side effects that you have to monitor for, she'll be the most meticulous person to look after, and none other than that. So if you are able to empower the mother enough that she's able to identify, tell you, or there's a phone number to call you up and discuss with you and explain to you, we can still be able to manage with oral opioids at home, with preventing any kind of overdosage or any side effects. Because obviously you will give it at a dosage which is required. You will explain, they'll be having enough of it, and there's a timing interval that you will do, that we will discuss about. And also about addiction, the fear that, if you give it for children, they'll be addicted to it in the later life. It depends upon how long you're using it, which opioid that you're using it, and what is the purpose that you're using it. Oftentimes, the reason why children ask or seek for a drug, we've seen in the hospital sometimes that if a child is constantly in pain and you give bolus doses of IV morphine or IV Fenta, because if you're addressing acute pain or severe pain, sometimes NS is flushed, because just because children are probably not reporting it correct, let's give a flush of NSNC, and we've noticed that the child will tell you that this is not the drug that you've given me, this is something else, because they know the effect is that pain relief will be there as soon as you give a bolus dose. So we have to be mindful that giving NS as a placebo to just see whether the child is really in pain is the worst thing that we can ever do. And I'm not saying that we have not done in practice. In our MBBS and training, it's how we have dealt with around us, and we feel that, oh, let me just try this and see whether is the child just malingering. Let me give a placebo of NS and see if that will be helping. And that's the most, worst part that we can do for a child. And they understand it, that there is a change. It's not the drug. You're giving me something else. And the reason why that drug-seeking behavior is because of the benefit that they derive from it. They feel that there is a change in their pain score. They feel that they're comforted. They feel that there is relief in it. So those are things that we need to be keeping in mind. And also we have to understand that, as Pandana really said, that "Mard ko dard nahi hota" is that statement that is very common in children. Girls and boys equally will constantly be like, I'm a brave girl, I'm a strong boy, I don't have pain, and they'll hold it. They'll not tell you. So these are things we have to address. So the main core principles when it comes to really management of pain is you prevent it first. When you know that, yes, there is a possibility that pain will occur, you anticipate it, have a prescription ready for it, preemptively given, say, for procedural pain. When you know that you're going to have multiple pinprick procedures, you're going to have an LP, you are having a bone marrow aspiration, you are going to access the Hickman line or the PICC line, and you're going to be using needles, you know that there would be pain. And for that, there are various modalities of how you would manage procedural pain. Always address it and treat it early. The longer the duration the child is going to be experiencing pain, more is the damage that will happen. And we need to address it earlier. Using a multimodal analgesia approach, I'll be coming to that on the few next slides. Individualizing therapy, because you can't have a cookie cutter approach. It can't be like, if this dosage or this prescription works in this child, it'll work in another, because as pointed out by Spandana, its assessment is what can derive you to the final understanding that what is the intensity, what is the source of pain, what type of pain it is, and depending upon that, your choice of analgesics on that. And most important is keep reassessing regularly. On an average, in a hospital, we practice is that at least at the first 24 hours, if a child is admitted with severe pain, you do every 2-hourly assessment so that you can adjust the dosages of opioids. And once you've achieved a good dosage, even a 12-hourly assessment is sufficient. So when you come at treatment of pain, the multimodal analgesia that I talked about is you want to include all various aspects, because when you see with kids, in some children, mild pain, even distraction will work. You don't always need to require to use analgesics for that. There are integrative therapies, like you'll have massage therapy, acupuncture, acupressure, or art therapy, music therapy that can come in. Certain children where you might have to consider a nerve block, a neurolytic block, or sometimes an intrathecal pump, because there is an intractable pain which requires the patient to be on an intrathecal pump that is there so that they can continue management at home. And most important, when we see to it, is that pain medicine is not only paracetamol, ibuprofen, diclofenac, and morphine. There are a lot of patients who have, or children who will have different types of pain, say like nociceptive pain, inflammatory pain, neuropathic pain. And then we forget that we have adjuvants for those neuropathic pain, like you have gabapentinoids, NMDA antagonists that you can consider using methadone or ketamine in such patients. Or if it is severe neuropathic pain, not responding to oral anti-neuropathic pain agents, you might have to consider giving a ketamine or a lignocaine challenge to see if pain can be controlled. Some patients, you might have to look at physiotherapy, because, give you an example, patients with ALL coming to the hospital, leukemias getting managed, they're on steroids, they start developing proximal muscle myopathy. And now this is something that is significant pain for them, and the child cannot do activities. In such thing, initial 48 hours when the pain is very severe is when we will start analgesics, but we ask physiotherapy to take over. And as soon as they start with therapy, pain resolves, strength is regained, we take out the analgesics maybe within next 4-5 days. And that's what is exactly is important for us, that we just come in for a short period, address the cause, and then move ahead. So taking into all perspective, if you have a clear idea about what could be there, involve probably some of these together to be able to assess pain, because that also helps a child to be able to cope well with it if next time it occurs. And if it's a mild pain, they might not catastrophize it. They know that, okay, with sitting down, mother knows, or the parents know, the father and mother would know, I can just sit down with the child and probably distract them, use distraction on their own, drawing, sitting and putting up some music or playing a musical instrument, whatever that helps to relax and provide that relaxation for the child and then parent accordingly. So my question to the group would be now is, how many of you are actually hesitant to use opioids now in practice? Pallavi, if you could just tell
Not
me.
hesitant. Yeah. So 3 people have said not hesitant. 2 people have said hesitant. Use not regularly use. Yes, hesitant. So 4 people have said hesitant. 5, but rest are not hesitant.
So we have a mix of a
Not
group.
in units. Yes, not in units.
And
Dr. Vendanu has said.
correct. I'm actually glad that a lot of you who said
Yeah.
you're not hesitant, you're upfront about it. And because it's common. We are not taught in practice. We are not, our only KD Tripathi mentions a chapter, but it's not put in practice. So thank you for actually telling me that very
Yeah.
honestly.
I think neonate there is a hesitancy.
It's quite possible because the worry is about the dosage, the calculations, availability of formulations, for that age group or weight-based calculation. Do you feel confused which analgesic to choose?
Yes. Yes, confused. Yes. Yeah, most of the people are saying yes sometimes. Most of the times, yes. Most of the people are. We have
I'm
5 minutes
glad to
more
hear
now.
that the right class that will help you, sort this doubt off is to help you to choose opioids and also to know which analgesic to choose when and why. So thank you, everybody. So just
We
brings
have
me to the idea that
we have
WHO
5 minutes to finish up. Just reminding.
I will. Thank you. So the most important thing that we need to remind ourselves is the WHO has given us very clear guidelines. When we have to look at how to manage, it's by the clock. So you have dosing at regular intervals as per the half-life of the drug. A lot of time prescriptions are 12 hourly, 24 hourly, SOS, as Dr. Spandana said, patient receives nothing when you write PRN dosage by the child. So you adapt it as per your assessment as what is the type of pain, using the appropriate route that most of the time you stick to oral because it's easier, manageable. You can have it on an OPD basis, but when it's not feasible, IV, subcutaneous, rectal, buccal, those appropriate routes should be considered, and by the analgesic ladder. Now, we have a WH analgesic ladder, which is commonly everybody feels that it's a 3-step ladder, but in children, it's only a 2-step ladder. It's it's simple, mild pain and moderate to severe pain. We do not have step 2. We do not have tramadol or codeine in use because children do not have the enzyme required for it to be metabolized into its active form, and thereby it can lead to a lot of toxicities in children. So with this guideline in place, the step 2 ladder, a 2-step ladder will have step 1 for mild pain, where you have acetaminophen, which is paracetamol, ibuprofen, moderate to severe pain with morphine, which is a strong opioid. Apart from that, fentanyl and methadone, which is available in India, avoiding these weak opioids, as I talked about it earlier. So when your most important thing that you need to remember when you optimize pain management is always review the response, escalate whenever it is needed. Appropriately, you go up on the dose. Try to keep the dose in such a way that you minimize the adverse effects secondary to the drug, and also communicate your plan. Let them know what drug it is, how you're going to go up on it, what needs to be done. You're sending a patient with a prescription to home. How do they monitor? When do they call you if their pain is not settled? How do they report it back? All of this has to be put in a plan and then explained to the child at an appropriate age, and otherwise the parents. So most of the thing is about selecting opioids. Now I know in practice, we look at morphine remains the gold standard as a first line, but depends individually upon the type of pain. Evidence is also about using methadone as the first line of agent in cancer pain. And individuals respond differently to different opioids. So we have to keep in mind that we start slow, low, and go up as required. So you give in a small dose, you see the response, and then you hike up as the response is there based on that. We talked about peripheral route being the most preferred. And always when pain is uncontrolled, look at a short acting formulation so that you can titrate the dosages quicker. And once you've achieved a good pain control, you could move to a long acting or a controlled release or a sustained release tablet formulations later on. Now, there are certain non-pharmacological measures which we talked about in multimodal. We have these entire list, and it depends upon child. As Spandana earlier pointed out, that each child has their own way of managing pain, reporting it, and also what they're engaged in. If a child hates art and you tell them sit and draw, they're not going to do it. They're just going to refuse it. So you have to think of what would help with the child. If required, get in a play therapist or a psychologist or social workers involved in how you can engage the child and help distracting or other things together. So my take-home messages for this is that pain relief is every child's right. You think multimodal, you treat proactively, like you prevent it, but you also assess it when it is underreported and also treat it and reassess frequently. Thank you.
Thank you, ma'am, to cover such a big thing in small time. Yeah, so anybody has any doubt they want ma'am to answer, Kritika ma'am or Spandana ma'am to answer regarding the assessment and the management? So there was a question, ma'am. I think we have answered to best of our capability that regarding the buprenorphine, can it be used in pediatric patient?
I don't consider using it so often because of its partial agonist antagonist action and the kind of formulations that are available for us. 0.2 milligram sublingual dose is a pretty high dose when it's an immediate when you give it, and you can't control with it. So it will be very difficult to handle in older children, say, the late teens, when it is due to any kind of a musculoskeletal issue. You could consider using 5 microgram buprenorphine patch and you can hike up based on response. But in cancer pain, it has not really given us great benefit as such. You could stick to morphine, fentanyl. That's more easier to titrate and more easily available because if a patch of buprenorphine itself is quite expensive.
So we have a lot of questions, ma'am. Dr. Aarti has asked, how do we de-escalate the drugs medications? So first question is that.
The most important fact is in chronic pain, unless you have understood and there's a physiological change in where the chronic pain is initiating from, say like in cancer, if disease has completely been cured and the child does not have any reasons why there would be pain, is where you want to start slowly de-escalating opioids or drugs at that point in time. But a child or any child with neurological issues, persistent spasticity, causing severe musculoskeletal pain, you might not be able to come down on the drug dosages at all. You might be able to minimize it to the least dose where side effects are minimal and it does not cause any kind of other organ dysfunction, but you won't be able to take it off. So it's very particular to that child and what is the source and what is the reason why pain is there. Similarly, in acute pain, like surgery and others, you'll have it only till a few days and then you de-escalate.
So another question is, what are the signs through which we can see that step 1 to step 3 we should go, means step 2. So has been asked, is it a more objective assessment?
I know this is a bit of a topic of this class today and also for the next class, but just to give that in a gist is that one is both patient-reported uncontrolled pain on the ongoing analgesic. Despite taking breakthrough doses of the drugs, there is no pain relief. And this NRS always stays above 5. Then you would want to switch to opioids, step 3, from the step 1.
Can
Spandana.
we use... Yeah, ma'am.
Can I just
Can
say
we
that
use ketorolac?
Pallavi, can I interrupt you?
Yeah.
Can I complete Kritika's answer before? I think there is a lag.
Sorry.
Pallavi is not able to hear me on time. Sorry, Pallavi. I think the
Oh,
lag is on.
sorry. Yeah.
No problem. I just want to add to what Kritika has said, that it is not necessary that if a child comes in 10 by 10 pain that we start with paracetamol, try for 2 days and then go to ibuprofen and then go to morphine. It doesn't have to be that way. If a child comes in 10 by 10 pain, I'm going to start morphine at that time. So it doesn't have to be that the ladder has to be that way. That is why WHO is still working on the ladder, because they are not very happy with the ladder. So if someone is in 10 by 10 pain, go directly to step 3. But my only answer would be, if you're starting it for the first time, monitor them well. Pallavi, over to you.
Yeah, ma'am. So one question, last question, I think. After that, we can answer in the chat box. How do you feel regarding using other NSAIDs for the pediatric patient, like ketorolac or we go naproxen or diclofenac, other than ibuprofen?
Age appropriately, we do consider using it. We do use ketorolac as a agent, as a single dosing at times when there's severe bone pain. Like, in cancer, we will use it for significant bone metastasis and they come in bone pain crisis. A single dose of IV is sometimes recommended to just suddenly break the pain cycle, and then you switch to a much more safer one, because continued use of IV ketorolac can have significant renal injury. So you don't want to use it as a chronic analgesic.
Thank you, ma'am. So I think we'll take a 3 minutes break because we have just 3 minutes left. Then we can restart at 8 o'clock. Is
Yeah.
that okay, ma'am? Or
Or
should
do you have like a timeline that we're going to give the 30 minutes for the case presentation and discussion later?
yes, ma'am.
Depends on the
So
group.
we can answer in the chat box also, ma'am, the questions, if it is okay.
Yeah.
Sure, is this a rest break for everybody? 2 minutes.
There's a question of preferred pain management plan for procedures. Now, it depends which procedures. If it's a simple needle prick, then you might just continue using a mixture of positioning, local EMLA cream, or like a Prilox. It's like a lignocaine or a prilocaine combination. If it's a much more bigger advanced invasive procedure like a bone marrow aspiration or IT procedure, then you might have to use sedation along with local numbing cream as well. So it depends on the intensity of the needle stick procedure that you will be doing. It is a bio break, Sushma ma'am.
I didn't realize, ma'am. That's good. I just want to say, beyond anything, there are two things I thought were important. One, for procedural pain, giving the child information, how much they want, and giving them choice, right? I think these are the two things that are very important for procedural pain when you're thinking about it. And what do I mean by that? Is, for example, you have to draw the blood and the child is crying, like, do you want your mom with you? Do you want to sit in the lap of your mother? Do you want it from right hand or left hand? It doesn't make a difference for me, but it gives the child some choice. And I've seen a lot of children who were like, no procedure. When I say right hand or left hand, it sits in their mind that, oh, I have to get it done. And this is the only choice I have. So they look at their hands and they're like, okay, this hand, right? So it gives them that control, because even a 4-year-old wants to feel in control of their body. So this is the kind of negotiation to start thinking about it. You will see that would be like a fantastic thing. The other thing, when Kritika was talking about placebo, I remembered pseudo addiction. And I think it's an important principle. I have had nurses tell me in the morning, this 3-year-old is addicted to morphine. And I'm like, interesting. How did you diagnose addiction, sister? And she's like, no, every time I give injection, within 1 hour, he's telling, give me that injection, give me that injection. And I'm like, sister, do you think he was in pain and he's telling that that injection is helping me give the injection? Because if I have written PRN, and the sister gives 2 mg, and the relief is only for 1 hour, the child is telling, give me that injection. So this is called pseudo addiction, where the child is not actually addicted to it, but is asking for the medication because I did not prescribe it well. So remember, this is something else you will see in your practice, and it becomes very important to explain to our staff that, sister, this is called pseudo addiction. This is because the child is getting relief that they're asking for the medication, not because they are addicted to it.
So I think it's 8:01. We can start the class case presentation. So, yeah, I'll request Dr. Pallavi ma'am to please start the case discussion.
I need help, hi, because my system is not working now. I'm
Okay,
using
ma'am.
phone.
So, ma'am, you want us to share the slides?
Jyoti is doing that. I've asked her.
Okay.
Yeah.
Okay, ma'am. Yeah, ma'am. She shared.
So, yeah. Next slide. So we started before this presentation today with this question that a 13-year boy with a known case of B-cell acute lymphoblastic leukemia, and he presented in a OPD with a severe crampy abdominal pain and with history of bloody diarrhea. So we will come to it, how we are going to assess this case. Next slide. So, patient details. He 13-year, weight 20 kg. He's a male child, admitted in IPD. Primary diagnosis, high-risk B-cell acute lymphoblastic leukemia. Other diagnosis can be steroid refractory, GVHD. Next slide. Next slide. So, pain and symptom including the relevant treatment. So, on onset, gradual onset of diffuse abdominal pain was there to this patient who had initially mild and then intermittent pain was there, which on, as we discussed today, that pain scale, various pain scale used for this patient, since he's a 13-year-old boy, so we are using the NRS on which initially the pain score was 4 out of 10 at first visit, which gradually progressed, and on the last visit it was 9 out of 10. It was sharply worsened over 5 to 6 days duration, coinciding with onset of loose stool, later bloody diarrhea. So you know that you have seen the Socrates and PQRST. So the site and character, it was severe, colicky, crampy, periumbilical pain, and occurs in waves of every 20 to 30 minutes, each episode lasting several minutes, and on closely linked to the bowel movement, that your associated symptom. Classic for gastrointestinal GVHD, visceral colicky pain, not a surgical abdomen. The pain was aggravated with any oral intake and just before each bowel motion, transiently relieved by passing stool, and that is your relieving factors, and by curling into the fetal position. Sometimes giving any position, pain is relief for the children. And there was no relief with any antispasmodic drug alone. So associated features was along with pain, patient has nausea with occasional non-bilious vomiting, appetite was poor, low-grade fever, generalized weakness, and fatigue, which we assessed on ESAS, that is a symptom assessment scale, which was scoring 3 out of 10. And there was a new erythematous maculopapular rashes on palm, soles, trunk, 3 days before severe pain. Next slide. So, symptom assessment scale which were used in this patient were numeric rating scale, which is, as we discussed, NRS 0 to 10. And on asking for this patient, it was initially 4 and then finally on 9 by 10. The other scales which were used were the Magic Glucksberg Acute GVHD staging tool, which was screened to use for his used to gut stage 4, that is used to stage skin, gut, liver involvement, skin stage 3 plus gut stage 4. Overall grading was 3 to 4 and defined the steroid refractory status. Then the stool output charting for this Bristol stool charting was used. And since the patient was also given IV opioid in severe pain, so pediatric sedation scales were also used. And for the performance status, Lansky Play Performance Scale was used, which was 50 around. Next scale, next slide. Past history. This case was diagnosed, as we know, with a high risk of BLL in 2018 at age of 3 years when the child was. And he was treated per standard ALL protocol. And on lab investigations and scans suggestive of relapse, which came in 2024, which was a marrow relapse, and reinduction chemotherapy was done for this patient. And patient was given a relapsed disease referred for the bone marrow transplant, for which his elder sister was a donor and she was fully matched, and the patient underwent MSD LO BMT with myeloablative conditioning. So this was his treatment history, and there was no prior major surgeries or any drug allergy to patient, no prior history of chronic illness, asthma, or any GI diseases before leukemia was diagnosed. Since the patient is 13-year-old and come into the adolescent age group, so had psychosocial screening was done, and it revealed a supportive home environment for this patient with no substance abuse or use of any drug or safety concerns, any thoughts of suicidal ideation. There was no such thoughts. However, because of this long treatment and the patient reported school non-attendance and cessation of all previous curriculum activities, restrictive eating behavior with family, and persistent low mood was noticed. This pattern suggestive of significant illness-related psychosocial withdrawal, and it can be a depressive mood symptoms, prompting referral to the psycho-oncology counseling team for further evaluation, which was done for the patient. So this is the chart which suggested of these symptoms. Next slide. Next slide. On psychosocial and family history, the patient has a nuclear family, and father is a shopkeeper who has taken extended leave, and they have moved to the near the hospital for the treatment. And the mother is a primary bedside caregiver. Her elder sister, who was the stem cell donor age 17, she carries a guilt around the relapse, and now that my cells are hurting him, thinking of as a GVHD, which she heard from the doctors and others. So there is a burden, sibling burden to her. Emotional and financial impact, financial strain from prolonged hospitalization and lost income. Family is anxious, sleep deprived, and fears losing him after coming so far. No prior mental health concern in child or family. Child appear increasingly withdrawn and tearful over the last week. Next, no, beyond that. So a spiritual concern for this patient, which was done according to FICA. Previous slide. The family, which is faith family, are the firm believer of God, and they do a regular prayer and maintain both at home and during the hospital stay. They also were doing the believing in God and doing their regular prayer. But the adolescent own belief was not much explored, a gap to address, and particularly around the missing school and the peer group loss. Importance, I for importance, which is like parent ask now, since they have been to this journey for a longer duration, and after the relapse and after the BMT failure, the things that why now and now, after all, he has survived, reflect that deep of their existential distress, that now why this came back and now why all the things are going on. So faith appears central to how the family is making sense of illness and prognosis. Community C, prayer practice which they are doing within the home and hospital setting suggested a supportive faith community practice. But adolescent peer group school community is not yet engaged, even not much addressed. Address A, in care, parents were well aware of the prognosis. Their core wish is that the child does not suffer much and the pain is relieved completely. The family wishes is that when the pain is completely settled down, they want to take the patient and go back home and fulfill his wishes, which is their plan. Their plan is to explore, from our side, the plan is to explore adolescent own belief directly, support completion of child wishes. Next slide. Communication. Parents were explained about the anticipatory symptoms and the goals of care, which will be done during, which will be explained in detailed when they will be discharged and when they go back to their home native place, what can they do in case of emergency. And they did not want any child to know more about diagnosis and prognosis now. So that was their wishes was kept. They were counseled in multiple sessions and they allow us to talk to the child and his siblings. Child used to feel happy when played or be his siblings and stayed at home. Now, we from our side, the child was provided with books and toy. He wanted with the help which was provided through NGO. Next slide. Sakshi. Now Sakshi will take over from here.
Hello. Yeah, is my voice audible?
Yes.
Okay. Okay. So thank you, ma'am. So actually there is a network issue here, so I don't want to disturb anything. So I will be keeping my camera off and I will be taking here from the management part. So next slide, please. Okay, so this chart is really the heart of why we had to act, and what you are looking at is this child's self-reported pain on the numeric rating scale, tracked day by day. So he started at 4 out of 10. On day one, and he was uncomfortable, but something we would normally expect to control with the standard measures. And by day two he was at NRS 6, and by day three at NRS 8, and by day four he was at NRS 9 out of 10, as you can see. So here I want to ask, like, it is the question. So I want you to sit with for a second. And this climb happened despite him already being on regular paracetamol and tramadol. So what does the rising NRS on an already adequate weak opioid regimen usually tell us? So it tells us we have failed that step of the ladder, and this isn't a dosing. Okay, so you want, okay, ma'am, I'll keep my camera off. Okay, I'll try.
No, Sakshi, you
Okay.
don't have to keep. It was for
Okay.
participant. I'm sorry. Yeah.
Okay,
Continue.
okay. So, yeah. So this isn't a dosing problem within the same step. So this is a signal to move us to the next step entirely. And clinically, he was curling up in bed, refusing to walk, crying with every cramp. So the NRS score and the bedside picture were telling us the same story. And by day four, we escalated to IV opioids. So, why does this matter for how we practice? Because it's a reminder that the WHO ladder isn't something we climb slowly and cautiously when a child is deteriorating this fast. So, we climb it as fast as the pain demands. Next slide, please. So this was a 9-day pain ladder titration, and so this slide gives you the whole 9-day journey at a glance, among the 4 steps, and each one a response to the step before it not being enough. So at step one, at days 1 and 2, so IV paracetamol, 500 milligrams 3 times a day. That was about 25 mg per kg per dose for this 20 kg child was given, and that was standard, safe, and first step. But as we just saw, that was inadequate, so pain went from NRS 4 to 9. And so in step 2, we moved to morphine IV infusion, and a 1 milligram loading dose was started, and then an infusion starting at zero point 0.3 milligrams an hour per hour, and that was titrated up to zero point 0.6 mg per hour. So now I want to ask, why morphine first and not straight away to fentanyl? So because morphine is our first line strong opioid, which is familiar, well studied in children, and also it is cost effective. So we only move away from it when something in the clinical picture tells us to. And now moving on to day 5 to 7. Uh, so step 3 is where we rotate, and not because morphine wasn't working, but because this graft versus host disease made morphine clinically risky, and we moved to a fentanyl IV infusion that was 10 to 20 micrograms per hour, which works out to be like zero point 0.5 to 1 microgram per kilogram per hour. So finally, at the step 4, and once he was stable on fentanyl infusion, so we transitioned him to a transdermal fentanyl patch of 25 micrograms per hour with the 12 to 24-hour IV overlap, while the patch reaches the therapeutic levels. And by day 9, he was stable and was ready for the discharge. Next slide. So this complete table gives you the uh, like the working document behind the last slide, the exact doses, and they are just as important, the exact trigger that made us change the course each time. So as I have discussed, that how we have gradually shifted him from NSAID, paracetamol to strong opioids. Next slide, please. So this is the rotation and the conversion logic explanation in this slide. So it is where we show our working, the actual reasoning and the arithmetic behind the two big transitions in this case. So again, I want to ask to stress this because it is the single most testable concept of this slide. And was this rotation driven by an inadequate dose of morphine? So the answer is no. And again, I would emphasize that it is the reason for rotation and not the dose driven. So three reasons drove it. First, it is the gut GVHD causing unpredictable motility and absorption, and morphine's active metabolite M6D risk the accumulation with fluid losses or the renal hypoperfusion. And next is and fentanyl, by contrast, having minimal effect on gut motility and no active metabolites, and is also being safer for the liver profiles as well. So why start at the conservative end of that range rather than the calculated midpoint? So because the opioid rotation tables give you a starting estimate and not the guarantee. So the cross tolerance between the different opioids is never complete. So the standard practice is a 25 to 50% dose reduction from the calculated equivalent, precisely to build in that safety margin. So the second transition was from IV fentanyl to transdermal patch on day 7 to day 8, as we have seen in the previous slides. So the logic behind is different. That this time it was the dose driven, because the pain had been stable for 48 hours or more on a steady IV rate of 20 microgram per hour or 1 microgram per kg per hour. So the IV and transdermal fentanyl are approximately equianalgesic, microgram for microgram at steady state. So the 20 microgram an hour maps at the nearest available patch strength, and we rounded up to 25 microgram per hour patch. So, but again, I want to ask a small question here. So, why round up rather than down or to the exact nearest number? So, because underdosing during a transition risk a breakthrough pain crisis in a child who is just stabilized, and a patch is much harder to adjust quickly than an infusion. So, again, with careful monitoring and for the safer direction use as well. Next slide, please. So along with the opioids, the other adjuvant medications like hyoscine butyl bromide, 10 mg SOS was also given for the antispasmodic, the colicky pain component. And along with that, the safety monitoring was done. Like mild sedation was noted after fentanyl up titration, and and it was closely monitored with the help of the pediatric sedation score at each nursing round, and dose adjustment protocol was done. And so the child was given some control via the PRN doses or the breakthrough bolus button, and that the complete plan for pain management using a 0 to 10 scale was done. Next slide, please. So again, I will discuss the collaboration and the partnerships between the like our team and the hemat oncology team. So we have spent a lot of time on these numbers, but none of that means that anything if it is not anchored to what this family and the child actually needs. And so let us talk about the goals of care. So, can I have the next slide? Okay. So, the current goals were like aggressive active treatment of the steroid refractory GVHD cases with the curative intent for the transplant course, which was combined with the excellent pain and symptom control. And this is a concurrent palliative care model and not the comfort only care. Now, so this is a okay, so for the family it was simple but profound. See their sons like patient the pain was controlled, and understand the realistic timelines for his response to uh, the GVHD drugs, and get support for the donor siblings guild, honest and regular updates that don't overwhelm them with the technical detail. And coming on to the patient's priorities as expressed, so his own priorities in his own words, and he wanted the pain to stop, and he wanted some sense of control, even something as small as his own breakthrough bolus button. And he missed his friends, his normal life, his cricket. uh, Now the team priorities. So our own priorities as the treating team will be like close monitoring for the response over the next 1 to 2 weeks, vigilance for opioid side effects, and importantly starting an early proactive advanced care planning, conversation with the family now in case the GVHD proves refractory to the second line therapy too. So let us close by pulling every issue in this case together into one working table. So can I have the next slide? So this is a complete comprehensive care plan which includes like this four domains as ma'am had explained in her slides. That is the total pain concepts, the symptomatic management, and the other like psychosocial and spiritual concerns as well. Can I have the next slide? So this is a summary of the entire case where a 13-year-old boy with 4 months of post-match sibling donor allogenic BMT for high-risk BLL developed steroid refractory grade 3 and 4 acute GVHD with severe colicky abdominal pain with NRS 9 and bloody diarrhea. and the pain escalated through paracetamol and tramadol to a continuous IV, morphine, to continuous IV fentanyl infusion, and bringing down to NRS of 2 to 3, and where the GVHD was also treated with the second line ruxolitinib after steroid failure. And so this case highlights the concurrent palliative BMT care with the significant psychosocial issues and donor sibling guilt and parental exhaustion and adolescent fear and withdrawal. Thank you. So here are the key questions for this case, which Pallavi ma'am will address. So
This questions is for discussion for everyone. So as we see this today whole didactic session and the case, so what everyone think that what are the children concerned in disease progressed cancer patient? You can put your thoughts in chat box. Uh, we can think beyond pain medicine or pain, since the concept of total pain has also been uh, explained previously in previous lectures. So that can be one of the thing which can be considered.
So Dr. Lavanya has answered, ma'am. What is death and where do I go after that? As the concern.
Okay, okay.
Missing home environment, Dr. Aarti has answered.
Yes, that is very common
Fear of
question.
death.
Okay, yeah. So these are many of these are the fear of death come to these patients, but the understanding develop with age appropriate in a different age group. But and apart from death, that is a very complex issue. I think it will be covered later also. But what are the children concerned in disease progress? So they have the concern that will I will be completely okay and go back home? Will I will have a normal life? Will we go back to the school or my education? So many things which come to the child life in his this journey of cancer experience, which may add to his pain episode too. So that's my thought. Anyone else can come and answer and add on. So,
The other thing we have to think about is if a child had a severe episode of pain and then got relieved, they're always scared that they might experience that pain again. So the fear of pain itself can be an important thing to think about, and that's why we need to reassure the child. And whenever possible, I always tell not just the mother but also the child about the frequency of usage of medication and also what happens when they don't use it properly and when they need to use SOS and as needed medication and everything else.
sure. Really. And the next question is when to initiate opioid pain medication in a pediatric age group needing palliative care, supportive care, and what all doses are involved. So the detailed management part will be covered in the next subsequent sessions. But yes, opioid can be initiated at any time whenever the pain is very severe and it is not controlled by the uh, analgesics, basic analgesics, so we can start opioid. So there is no age as such. We have to start opioid in adults or by after this age. So as per the need, it can be started in a small children also. How can we help families to understand and diagnosis of an advanced illness? It depend upon the many sessions of communication is involved in making family to understand. And in this case, the one question is missing. That is a sibling which she was having that after giving being a donor, she could not, she was having the guilt that my cells are hurting my brother. So that has to be addressed in this case. A session, maybe a clinical psychologist should be involved to address her guilt and to make her understand that there is no fault of her, and to the patient child also, both. That's all.
Uh, There's a question, ma'am, I think to Pallavi, ma'am, regarding the last, regarding how to make them understand. That is a peer group discussion recommended for families. Okay, ma'am answered the
Peer group discussion. Is peer group
discussion.
discussion recommended for families?
Yes, ma'am.
Yeah, I didn't get peer group means what? A family discussion is required for the whole family if a session for such progressive disease or when there is a relapse. For any chronic illness, a family discussion is, yes, we should do it.
I think also probably the question also means, Pallavi, to bring multiple families who are facing the same diagnosis or same situation too.
Supportive care, something like that.
Yeah.
Sessions for all the family, bringing them together. Yes, that is absolutely a very good idea. In fact, there we do sometime and bring all the caregivers together, and then that is very they open up with their own experience and they share and what they can do, and it's learning for all of them also and for us also. That is that should be done.
Just remember, I had a Duchenne muscular dystrophy child who underwent a spinal correction surgery. Not a child, he's an adult now. And his mother did not like the experience. So, when we had a SMA type 2 child who had to undergo scoliosis surgery, someone introduced these two mothers, and the first mother scared off the second mother. So, that is why I strongly believe what is the goal of bringing them together? You should know the temperament of the families. And third, the facilitator should be able to make them talk about things that are important, not that that doctor is bad, we should get them fired and all those things.
That's noted.
So anyone has doubt that they want ma'am, Spandana ma'am, Pallavi ma'am, and Sakshi to cover?
I think,
Uh,
Pallavi, it
so,
is sorry to speak in between. It's 8:33, and the participants want us to leave them in time. It will still take them about 15 minutes to leave us. So I suggest, if there are no more questions, I'm sorry that I had to interrupt you. If there are no more questions, I think it's time for us to wind up and let them do the post-quiz question.
Yes, ma'am. Yes, ma'am. So we'll
I mean,
end
the
session.
post-session MCQ quiz, yeah? Okay. Thank you, Pallavi, for being a great facilitator. And thank you to all the faculty. Superb, absolutely superb lecture.
Pallavi and
Please
Sakshi,
continue.
thank you so much. Such a great case and made us think about so
Yeah,
many aspects of it. I agree with you, Sushma ma'am.
absolutely. Yeah, absolutely. The girls have done. I mean, women power, sorry, yeah? Entire
Thank you,
five.
ma'am.
And Jyoti. 6 of you all, yeah? Okay. Thank you.
Thank you.
Over to
Thank
Jyoti
you.
and to Pallavi for winding up the session.
Thank you, ma'am. Thank you for the today's session. So after this, we have a post test for 10 minutes. I'll ask the participant, can Jyoti provide the link for the post test?
I'm posting the link on the chat box. I request all of you to please keep your videos on while you're doing this. Yeah. We have 8 minutes. I'm posting the program. We have 8 minutes to finish this, and then after that, we'll have the feedback.
Jyoti, do you want to stop recording? I will take leave now. Thank you, everyone.
Thank
Bye.
you, ma'am.
Thank you.
Thank you, Pallavi. Thank you so much for
Thank you.
facilitating today.
Thank you.